All right, let's talk about something that comes up all the time in clinical practice. You get an imaging report back, and boom, there it is, an unexpected liver lesion. It's that moment that can cause a ton of anxiety, right? For the patient and honestly for us too. So today, we're going to build a really solid high-yield framework for exactly how to think through this. Let's dive in.
Okay, here's our game plan. We'll kick things off with the incidental finding itself. Then, we'll cover the common benign tumors you'll see. After that, a big section on hepatocellular carcinoma, or HCC, what it is, how to spot it, and how to treat it. And we'll wrap up by looking at a couple of other key malignancies you need to know about. So, picture this. You get that call from radiology, or you pull up the report, and you see the words, liver lesion noted, the classic incidentaloma. Right at that moment, your brain has to hit a fork in the road. And the absolute first question you have to answer is this thing benign or is it malignant? Because that one single distinction is going to drive everything you do next. And really, that's the whole ballgame, isn't it? Are we looking at something we can just chalk up to a benign curiosity, a leave-it-alone kind of lesion, or is this a real threat? The first sign of a cancer that needs our immediate attention. Nailing that down and doing it fast is what this is all about. Okay, let's start with the good news category, the benign tumors. Getting these right is so important because a confident diagnosis here can save your patient a world of unnecessary stress and, invasive procedures they don't need. We're going to focus on the two big ones you're most likely to run into. So let's break down the two most common benign lesions side by side. First up, you've got the cavernous hemangioma. This is by far the most common one. The key thing is it has no real risk factors and pretty much zero risk of turning into cancer or rupturing. So if your patient has no symptoms, you just leave it alone. Simple. But then, on the other side, you have the hepatocellular adenoma. Now this one is different. The classic story, and a total favorite for board exams, is a woman who's been on oral contraceptives for a long time. And unlike a hemangioma, an adenoma can bleed or even become malignant. That means the management is totally different. You have them stop the OCPs, and if that lesion is big, say over 5 centimeters, or if it's found in a man, it's probably got to come out. Okay, let's shift gears. Now we're talking about the one diagnosis we absolutely positively cannot afford to miss, hepatocellular carcinoma, or HCC. This is the big one, the most common primary liver cancer, and it almost always shows up in a very specific setting. And this right here is a super fundamental point. You have to get this. Almost all HCC grows in a sick liver. We're talking about a liver with underlying chronic disease, usually cirrhosis. It doesn't really matter what caused the cirrhosis, could be Hep B, Hep C, alcohol, or increasingly fatty liver disease. Now there's one major exception you've got to burn into your brain. Chronic hepatitis B. Hep B is unique because it can cause HCC even in a liver that isn't cirrhotic yet. So if you have a patient with a healthy liver and no risk factors, HCC drops way, way down on your list. So in these high-risk patients, how do we actually make the diagnosis? Well, it's all about high-quality imaging, like a multi-phase CT or MRI. And to make sure everyone's on the same page, we use a standardized language called LIRADS. Think of it like a universal translator for liver lesions. It's a system that lets radiologists categorize what they see, which is incredibly powerful because it often lets us diagnose HCC without ever needing to stick a needle in a patient for a biopsy.
All right, so let's see how this all fits together in a real-world pathway. We're going to look at the number one imaging feature that the whole LIRAD system is built on, and then, crucially, how that LIRAD score tells you exactly what to do for your patient. This right here is the money shot, the classic radiologic signature of HCC. So on a special CT or MRI with different phases of contrast, here's what happens. In the early arterial phase, the tumor lights up like a light bulb. It's super bright. Why? Because it's getting a ton of blood from the hepatic artery. But then, as you move into the later phases, the contrast just washes out of the tumor faster than the rest of the liver. So it goes from bright to dark. That specific pattern, what we call arterial phase hyperenhancement with washout, is the absolute hallmark of HCC.
So what do we do with that washout pattern? Well, LIRADS boils all the imaging features down into a simple score from 1 to 5. And as you can see, the management just follows the numbers. An LR3 is kind of in the middle, so we'll watch it and rescan in a few months. An LR4 is looking pretty suspicious, probably HCC, so we're thinking about a biopsy. But here's the most important one, LR5. A LIRADS 5 lesion is so specific for HCC that we call it definitely HCC. It's a radiological diagnosis, no biopsy needed. You can go straight to treatment. That's a huge deal in modern liver cancer care.
Once you've got the diagnosis, what are the treatment options? Well, it really depends on the stage of the cancer and how healthy the rest of the liver is. If we catch it early, we're going for a cure. That could mean surgery, a liver transplant, or zapping the tumor with ablation. For tumors that are a bit more advanced but still just in the liver, we can use what are called loco-regional therapies, things like TACE or TAR, to control them. And then for disease that has spread, we move on to systemic therapy, and we have some really good options there now. Okay, so HCC is clearly the main event when it comes to primary liver cancer. But there are a couple of other players you need to have on your radar. Let's quickly go over two more to really round out our differential. First up is a really unique flavor of HCC called fibrolamellar HCC. And honestly, this quote just says it all. It typically hits younger folks, under 35, who don't have chronic hepatitis or cirrhosis. So basically, you can take everything we just learned about risk factors for regular HCC and throw it out the window for this one. It's the total exception to the rule.
Yeah, the difference is just night and day. When you hear fibrolamellar HCC, I want you to picture a young person, maybe in their 20s, with a perfectly healthy liver, no cirrhosis at all. Their AFP tumor marker, normal. And the imaging? It often has this classic central scar. It's a completely different patient, a completely different story than what we see with classic HCC. And the last big one we need to cover is intrahepatic cholangiocarcinoma, or ICC. The name tells you what it is. This is a cancer that comes from the bile duct cells inside the liver. Now, while cirrhosis is a risk factor here too, the absolute classic association, the one you've got to know for your exams and for the wards, is primary sclerosing cholangitis, PSC. And for these folks, getting them to surgery is their only real shot at a cure. So there you have it. That's our high-yield framework for when you find that incidental liver lesion. We've gone from the initial discovery, sorted through the benign stuff, and really dug into HCC and its mimics. But I want to leave you with one final thought. The single biggest cause of cirrhosis is quickly becoming non-alcoholic fatty liver disease, or NAFLD. That means the number of people at risk for HCC is just exploding. So the huge question for all of us is, how are we going to survey and protect this massive growing population? That's really one of the next great frontiers in liver disease. Thanks so much for tuning in.